Good morning, everybody. We've got a great program this morning. We have a couple of cases that were submitted, and if it's okay with everybody, I'd like to hold them till the back end of clinic. I'd like to introduce our guest, who is Dr. John Ganser. Dr. Ganser is a native Nevadan. He's been a great colleague for us in our weight management program here in Reno. He's a graduate of what used to be UNSUM, now University of Nevada, Reno School of Medicine, and trained in surgery at Baylor, and thoracic surgery in England, and special extended training in laparoscopic surgery. And he is now the director of Western Bariatric Institute. That's the correct name.
Correct.
And I've really been looking forward to him joining us because this is such an exciting area of medicine. And though I hate to admit it, we've got surgeons now who are curing another of our diseases. And but I think they're actually they're really helping us and our patients enormously. And I think the future is incredibly exciting. So I think there's always confusion about the available techniques and how the procedures have evolved over time. So I think this is a great opportunity for us to get up to speed with the current status of bariatric surgery, and for you all to know what's available in our community. So without further ado, I'm going to turn it over to Dr. Ganser.
Great. Thanks, Evan. One point of clarification: I went to undergrad here. I went to med school at Baylor.
Oh, sorry.
And I need to change my slide here because it says UNSUM, and it's
Yeah.
you and our SOM now, I guess. Huh?
Yeah, and even that is a. Yeah, we talk about branding later.
Yeah,
That's a whole thing, right?
It's the big N now, right? It's like the one you see on the hill.
Yes.
Well, yeah, I've included in this talk. You guys have access to these slides. It's a pretty comprehensive talk, and it would take probably a couple hours to really delve into every slide. So some of these slides I'll kind of gloss over. I know you guys want to hear about surgery, what we have to offer. You know, some of this is repetitive, so I'll kind of go through some of this. Just I like to paint a broad stroke view of obesity, the obesity epidemic, my perception of it, but also, like Evan was saying, the evolution of bariatric surgery. I mean, it's kind of come out of the closet, so to speak, and become very mainstream. And the reason is there's more science behind it now. You know, 20 years ago, surgeons were making things up. It was a dangerous time. I remember Oprah doing an expose on bariatric surgery and how dangerous it was and all this. Well, I think we've really come a long way with that. We've made these very mainstream surgeries are very accepted. There's much more science behind anything we do. So we'll leave it at that, and we'll get into it as we go along here. So we'll have plenty of time for question and answer at the end as well. So really what we're going to go over is really some of the statistics, some of the mechanisms we realize about not only obesity as a metabolic disease, but how surgery affects the metabolic process going on. And we'll also go into the weight loss surgeries themselves, some of the potential complications. I think there's a lot of misperceptions out there about the risk of obesity surgery, and I think we've made these actually very safe surgeries. So you all know the body mass index. You know, we can't just say how much overweight are you. It's really about your height and weight. And so we get these big charts about BMI, or you can Google search, you know, BMI calculators. You know, there's limitations to this. You know, bodybuilders who have 9% body fat can have a BMI of 35. You know, so it's not taking into account muscle. So if you want to be more specific, you know, we can do much more body analyses, which we do on a lot of our patients. We do body fat percent, things like that. We can track that as they lose their weight as well. So it's a little more specific. So all the classes of obesity, I'm sure you're all familiar with this, but the ones that currently are being treated with obesity surgery or weight loss surgery are class 2 and class 3. So over BMI of 35, you know, 35 to 40 if you've got some comorbid conditions. Above 40, really, you don't even need any comorbid conditions, and that's the Institute of Health kind of set forth some of these policies. There's a lot of research being done, you know, with class 1 obesity, BMI 30 to 35, and those patients with poorly controlled diabetes. some studies are showing that we're getting much better control of that with say, gastric bypass surgery in those patients. So I do think we'll push the margin down a little bit on this as well as time goes on. Well, don't need to tell you this is an epidemic. I mean, 69% of the U.S. population are overweight or obese, so BMI greater than 30. And I think really the striking thing is in our kids. You know, growing up back in the 60s and 70s, very few kids around me were overweight. Well, you look at schools now. I've got kids all through high school and everything, and it's very different than it was. And so this is an epidemic. The bottom line is at the bottom here. You know, right here, 365,000 obesity-related deaths occur annually in the United States. So it's crazy. All right, I've got my notes here on my phone, so I got to keep it. It keeps shutting off on me. Well, this is also a global problem. 3.4 million deaths worldwide. You know, this was a study supported by the Bill and Melinda Gates Foundation, published in Lancet a couple of years ago, just showing the rise in worldwide obesity. Medical costs. Total medical costs felt to be $168 billion, and this is old. This is old data. You know, I haven't been able to find a good because I think the number is so big now. It's interesting that at this time it was about the 168 billion was about the same amount of money people spend on fast food. Interesting. I got to throw these little things in there. Yeah. Well, if you look at it, you look at some of the other things. Medical spending, 9.1% of our spending as a country are spent on medical care. 80% higher prescription drug costs than for normal weight individuals. So there's a real cost of obesity on our society. Well, obesity was kind of looked at like smoking, or something. You know, it's a disease of lifestyle. Well, fortunately, in 2013, the American Medical Association finally said this is an actual disease. This is a metabolic disease process. And so, you know, insurance companies are now paying more for not only surgery, but they're all paying for health benefits for going to gyms and kind of trying to modify lifestyle as well. So fortunately, it's being recognized as that, so we can actually treat it as a disease. Well, what is morbid obesity? It's a disease where excess body fat is really affecting health. Not only health, but psychological, social, physical, economic impacts as well. Now, there's a lot of health issues associated with obesity, heart disease, diabetes, and all of this. You know, the list goes on. Oops, there, I kind of skipped by. Bottom line is early death. You know, we got to affect that as well. And I like this slide because that one. But it just kind of shows you. I mean, there's only one body system that I can think of that is not affected by obesity. That's our bones. Obese people don't tend to have a lot of osteoporosis. So that's one good thing. Cancer. A lot of people don't realize that cancer happens at a much higher rate with obesity. And we'll talk a little bit of that. I've included some slides about cancer and its relation to obesity. But you know, obesity is felt to be second only to smoking as kind of a preventable cause of cancer. It's kind of interesting to look at it that way. So kind of a staggering statistic, 65, only you have a third chance to make it age 65 if your BMI is over 35. 65, and I operate on 90-plus-year-olds all the time now, you know. We're living to be older. So when you look at this, 65, that's like nothing. That's getting very close here. So it's closer and closer every day. Oh, look at that. Fancy stuff. Well, kind of an interesting slide looking at health risk associated with your body mass index. Obviously, as you go low, it's unhealthy, but as you go high, health risk goes up pretty dramatically. I mean, almost a threefold risk of dying. And it tends to affect white men and women more than black men and women. Why is that? I mean, so there's some genetics that play into this as well. Your tolerance of obesity. There's some interesting studies done on that. You know, kind of to break it out, white men, because almost a threefold risk of mortality as your BMI goes up. Women are more tolerant. They're designed to carry more, you know, raise children, things like that. So, you know, there is some variability in that as well. Well, I'll kind of run through some slides that are that kind of show the explosion of our obesity epidemic in the United States. They were doing these studies with, and this is over BMI of 30, looking at each state and their percent of their population with a BMI over whatever percent, over 30, BMI over 30. And so starting out back in 1985, not a lot of states were reporting in the white there, but those that were, you know, were getting like less than 10% of the population had a BMI greater than 30. Well, as we go along, here's 1991, 6 years later, you can see the explosion going on. We got some darker colors. Now, most states are reporting, except Colorado there. A lot of states into that 15 to 19% of the population over a BMI of 30. Here's in 1996. 99, a new color, greater than 20%.
New category.
New category, so we have to keep making new colors. Oh, there we go, 2002. Good southern cooking there.
Yeah.
And then 2004, quite a few states are getting greater than 25% of the population. Very few blue states left. 2007, you know, only one blue state left.
That's Colorado.
That's Colorado. Sorry, yeah, you're right.
Yeah.
I knew Colorado State.
They got it good. Yeah. They're doing something right.
That's right. Outdoorsy people right there. 2010, we got crosshatch, greater than 30% of the population in those. They changed the reporting on this and the style a little bit, but this is 2011. If you can't read that, it's kind of dark there. And there we go. A couple of states with greater than 35% of the population. So pretty striking to see the explosion of this, and we'll kind of go over some of the reasons that this might be happening. I mean, obesity is an energy imbalance, right? Intake of calories are greater than expenditure. It's pretty simple. Well, maybe not. Maybe a little more to it than that. Endocrinologists, you know, this is I have a field day with this now. There's lots of
we got to stay busy. You know?
All right, but there's many things that play into this. Genes, metabolism, you know, lots of things play into it. And here's a nice slide kind of showing the overlap of genetics, environment, behavior. You know, people might have the genetic predisposition, but the genes aren't activated unless they're in the right environment. And so there's tons of research going on. It's a pretty fascinating topic. Well, the way we eat has changed dramatically, right? Much more processed food, much more calorie density in the food we're eating compared to what we used to eat. Cheap food is bad food, right? I mean, that's been known for a long time. You know, in poor areas, there's limited access to healthy options as well. It's kind of interesting slide looking at dietary energy supply. I mean, how many calories per person do people purchase in a day, for a day of life, right? So in 1961, the number was about 2,600 calories per person. As we've gone on down here, you know, that's the average in the United States. You know, as we've gone down here, oh, there you are. The next one is 2003. So it's from 1961 to 2003, it's gone up to 3,700 calories per person per day in the United States. And most of those calories are carbs. You know, it's not good calories that we're purchasing, right? You know, our activities have changed, less outdoor play, our work environment's changed, much more sedentary. You know, in inner cities, it's unsafe to get out and exercise and do things. And so it's a real problem in inner cities. There's a lot of environmental variables, lots of studies being done on you know, field development and sleep deprivation, but viral infections, gut microbial composition. Bottom line is obesity is a metabolic disease. So how does that work? Well, some really smart people got together and looked at this. And you know, it's a balance between energy expenditure and energy intake. And where those two lines cross is kind of where your weight is. So it's like the set point for weight. Now, all these hormones that are supposed to protect our weight are supposed to keep our weight at a normal level. Well, all of our body processes involving in weight are really geared at keeping us from starving to death, because that's what humans have fought throughout eons, right? So that's where the problem has happened, though. We don't have that mechanism to protect us from obesity. And so whether it be the genetics or environment, all of these processes have just driven some patients' weights up. And so that's where their balance is. They try and diet, they lose a little weight, all these mechanisms kick in high gear that are supposed to keep them from starving to death and push their weight back up to what their metabolism thinks is a normal level for them. So we'll kind of go over this a little bit. This is where we might skip through some of the stuff. There's these genes that have been identified that don't really have any known function. This is the fat mass obesity gene that was found, and carries this gene, had a 3 kilogram heavier weight. Well, so looking at the genetics, are there ways to roll this into some sort of treatment? We don't really have all the answers to that, and probably won't for some time. You see remember the old studies? I remember in school, you saw these monkeys with little probes. They'd stimulate one area of the hypothalamus, and they'd get obese, and stimulate another area, and they starve. So we've known from a long time we've got these feeding centers in there, but how do they work? I mean, we didn't really understand all the mechanisms of how they work. Well, there's a lot of brain signals, lots of signals we're uncovering more all the time: glucose, insulin, cholecystokinin. In 1994, we discovered leptin. There's some mice with an inherited genetic mutation that basically didn't have it, and they'd be overweight. Administer leptin to these mice, and they would lose weight. So we've been working on this for a long time. It's a rare cause of obesity in humans. So it's supposed to reflect triglyceride fat storage, and so there's increased leptin production. And in obese patients, there's actually higher levels of leptin than in lean individuals. Well, there's felt to be these proteins that are causing leptin resistance. And so it's kind of like, it's hard to understand why that would happen, but bottom line is leptin's not really the cause, it's the leptin resistance. And so how do we convert that into therapy? Huh? There's all sorts of visceral responses and gut hormones as well, vagus nerve, stretch receptors. One of the most powerful ones that we've kind of been focusing on a little bit in recently, and especially in relation to bariatric surgery, is ghrelin. It's a hormone, the only peptide known to increase appetite. It's kind of the big anti-starvation hormone. It's released from the stomach even before feeding. So you look at that commercial, you're looking at the food, you're smelling the food, this is making you hungry so that when you do get food, you're going to eat. I think the kind of analogy I like to give is, it's like that lion out on the savannah, hasn't eaten in 2 weeks, and all of a sudden an antelope comes by, and boom, that hormone turns on, they overeat, and then they store it all, and then they sleep for a week, right? And that really is kind of the way this works. It makes patients overeat. And so one of the things we found with bariatric surgery is there's a marked decrease in ghrelin afterwards. And so we're getting rid of that anti-starvation hormone. Catch up on my notes here so I don't miss any important points. Adiponectin, starvation signal. Again, you can go over some of these, but again, this just kind of goes back to our slide, is how does this affect all of these problems that we're having in our bodies with weight loss? We talk a lot about metabolic syndrome, sleep apnea, very common. We've got one of our case presentations today that I think will focus on that a little bit, and some cancer as well. This just kind of goes over the health risk associated as the BMI goes up. So as these colors go up, BMI is up into the greater 40 range. And so you can see the input of obesity on diabetes. Again, cancer, I think that surprised a lot of people. Lots of other problems in between. So metabolic syndrome affects lots and lots of people. You guys know all about metabolic syndrome. There's a good slide. I like this. I like to include this with my medical school lectures when I give lectures on this, and kind of flash it up and give them a test on it. They're all scribbling, preventing, frantic. But, you know, suffice to say, kind of a more simplistic rules slide. Central obesity, insulin resistance, hyperinsulinemia, and all of the problems go along with it, leading to heart disease, which is the #1 cause of death in adults in America, right? Well, sleep apnea, often it's a mechanical issue. There's a lot of fatty tissue in the back of the throat that can lead to the sleep apnea. You guys know the Epworth sleepiness scale. There's been lots of really good studies done on this. But just some of the outcome studies after this, sleep apnea prevalent in about 1/3 of obese patients. After surgery, there's still some people that have it, but there's much better tolerability. And I think really I'll kind of go through this a little quickly. About 75% of patients will get off their CPAP machines. Skinny people get sleep apnea as well, but it's pretty dramatic, the results of weight loss surgery and weight loss of any kind, really, on sleep apnea. Cancer, again, I think it's surprising for a lot of people that cancer happens at a higher rate. Well, there's a lot of hormones, estrogen produced in fatty tissue. You know, it's kind of like throwing fuel on the fire with breast cancer and endometrial cancer, things like that. Lots of new cancers. We've talked about this a little bit. I think the bottom line on this slide, an increase in BMI of 5 kilograms per meter squared increases cancer mortality risk by 10%. So pretty dramatic. You know, mechanisms, I'll let you go over that. We don't need to talk about mechanisms, but there's the Swedish obesity study. The Swedish have a lot of great studies on obesity because it's all national health service. They get everybody's in the system. They can follow people, and it's great. Some great studies have come out of this. But 13-year follow-up after bariatric surgery showed a significant decrease in incidence of breast cancer in women. So one of the proposed mechanisms is increased killer cell function. I'm a surgeon, so I won't get into that because that's... All right, so how do we solve this? Well, there's many levels, you know, societal changes in diets, increased physical activities, you know, schools to help improve food offered to children, getting candy machines and soda machines out of schools, thankfully. A lot of employer-sponsored programs like we talked about, healthy food options, wellness benefits. You know, they work out at gyms where like Hometown Health will have this whole wellness benefit. I love seeing the patients coming in, these people, they aren't even patients, they're coming in with their wellness benefit, and I see them working out right next to me and trying their hardest. It's frustrating, you know, once you reach a certain level of obesity, it's hard with diet and exercise to achieve significant weight loss. So again, talking about diet, and really this is applying to patients with a BMI over 35, 40, only about 1 in 20 can lose an appreciable amount of weight and keep it off. Again, we've got all these hormones they're fighting against. And so diet, exercise, behavior, pharmaceuticals, and again, down here, we're last resort, and we should be. Well, what's our treatment? As primary care providers, you know, above BMI of 25, yeah, lifestyle modification, get into that 27 to 30, sometimes pharmacotherapy. There's some newer drugs that are working a little bit better, a little bit safer as well. And really, it's once you get into the BMI of 35 to 40, we start talking about surgery as an option for these patients. Well, what are prescribed by physicians? And this is for patients with a BMI over 40. Well, exercise. Everybody, you know, we always talk to them about diet and exercise, and that should be the first thing, because some people can lose an appreciable amount of weight with diet and exercise. Nutritional counseling, behavior modification, some drugs, and then only 15% are offered bariatric surgery. And so why is this? You know, I think we're kind of overcoming a black cloud of bariatric surgery where a lot of people, when we first started doing this 17 years ago, there was a real negative bent towards bariatric surgery, and for good reason. It had been unsafe, it had been unstudied, you know, there wasn't a lot of science behind it. Well, this is a great study on some of the best diet and behavioral modification that we can offer, where there's initial intervention, pretty good weight loss. This is kilograms, so that, you know, people are losing up 40 pounds, something like that. And then leave them to their own devices and follow these patients. And you can see with all of the different modifications of this, at 5 years, their weight was higher than when it started. So unfortunately, it's not working great. Well, there's a high attrition rate with diets. Everyone's on the diet initially, but within 10 weeks, less than 50% of patients can stay on the diet. So, National Institute of Health, I like to, that only surgery is proven effective over the long term for most patients with clinically severe or morbid obesity. This is not a surgery group. This is the National Institute of Health saying this. So let's talk about surgeries. Lots of surgeries have come and gone through the years. And we've kind of come down to where locally here, we do Roux-en-Y gastric bypass and sleeve gastrectomy. There's some programs around the country that still are doing the biliopancreatic diversion or duodenal switch as part of that as well. We're no longer doing the lap band. It worked okay for a while, but back then when we were doing that, we had really the option of two extremes, the gastric bypass or the lap band. And lap band worked great for a lot of people, but for a lot of people, it had complications, it had to be removed, it had intolerance to it. We'll kind of explain a little bit of why that might be. So really the three surgeries locally that we've been doing for the past 17 years, Roux-en-Y gastric bypass, where we're making a very small stomach pouch and then unhooking the bowel here, bringing it up. So the roux limb here is about 100 to 150 centimeters. All the digestive enzymes coming downstream, so there's a shorter length to absorb nutrients below. So there is some malabsorptive component to it as well. Lap band is just an obstruction here. We have an inflatable band that goes around the stomach that we can adjust. The support sits underneath the skin. So it's really just restricting that. Whatever gets through there is processed normally. I call Starbucks the band killer, right? I mean, you see people coming in for their band adjustments carrying Starbucks. You go, really? Okay, that's not going to work. But we'll talk a little bit about some of the physiology and why that might be so too. A newer kid on the block, and really it's kind of taken over as really the most common surgery done worldwide is the sleeve gastrectomy, where we're actually removing 80+% of the stomach. We're removing the capacity part of the stomach. A lot of people think it's brand new. This has really been around for decades. It was initially the first stage of like a two-stage procedure, like they do a duodenal switch, where they get the sleeve gastrectomy, and then once their weight got down to a healthier level, safer level, they'd be converted to either a duodenal switch or to a gastric bypass. Well, a lot of these patients, for a variety of reasons, never got the second stage, and so they followed. Well, they kept losing weight, and so scratching their heads, why they shouldn't be losing weight? And we looked at this. I've been hearing about this in meetings for 17 years. I've been doing this. A lot of surgeons saying, this is going to be the greatest thing. This is going to work. And we're like, well, show me the data, because we do things science-based now, right? So good long-term data started coming out about 10 years ago with the sleeve gastrectomy being a viable option as a standalone procedure. We'll talk a little bit about why that might be. Well, here's how bariatric surgery is felt to work. Yeah, we're limiting calories, but we're changing metabolism. Remember, we were talking about all these hormones that are kind of out of whack, that ghrelin that's keeping the weight up here. Well, after bariatric surgery, there's a decreased energy intake, but also an increase in energy expenditure. The brain goes out of starvation mode by getting rid of ghrelin. Your brain says, oh, we're getting plenty of food now. We can actually raise metabolism and burn more calories. And so that's what drives our set point for weight back towards normal. It's not all the way to normal, but patients are losing a significant amount of weight and keeping it off over the long haul. But they aren't feeling hungry all the time. And that's one of the things, just to go back to the previous slide, ghrelin's produced in this part of the stomach up here. And so that's where the aha moment came 10 years ago. This data started coming out right about the same time long-term data on the sleeve came out. And it's like, oh, that's how it works. We're getting rid of that hormone. With gastric bypass, we're bypassing. It's not getting stimulated, but it's still in there. That's one of the problems with the band. It's not being affected. So patients with lap band didn't get that metabolic effect that patients with the sleeve or gastric bypass were getting. So it kind of makes a little more sense. Well, let's look at resolution of some of these comorbid conditions. I mean, we can focus on a few obvious ones. Sleep apnea, we talked about that. Most studies show about 75% of patients getting off their CPAP machines. Hypertension, 60 to 70% of patients can get off blood pressure medicines. Big ones right here, diabetes. Some studies showing as high as 96% of patients after, and this is after gastric bypass surgery for the higher levels of diabetes. The sleeve does pretty good, but not quite as good as gastric bypass, and there's reasons for that. With gastric bypass, food gets to the distal gut quicker, activating your own body's gut hormones to kind of get rid of the insulin resistance. And so there's a lot of studies showing that gastric bypass for those real bad diabetics is probably still a better procedure in the long haul. No one's going to say we cure this, though. If there's any weight regain, we see that happen. Some ranges to regain weight. We'll show some studies on weight regain. Down here, relative risk of mortality, 89% reduction in a 5-year period. I'll show you one of the studies on that as well. Again, this is out of the Swedish literature. Thousands of patients getting non-surgical treatment for obesity versus over 1,000 patients. And this is back when this was gastric bypass surgery, showing really a dramatic reduction in risk of mortality in 5 years. So pretty cool to see some actual data on that. Well, what's the risk? There's obviously risk to surgery, right? Well, when you look at it, gastric bypass or any weight loss surgery compared to some of the things you don't really even think about the risk of, right, it's actually lower. Why is that? And this is when performed at a bariatric surgery center of excellence. Remember back 20 years ago, the surgeons were making surgeries up. There was a lot of deaths, all this. Well, in 2005, the American Society for Bariatric Surgery, which is now the American Society for Metabolic and Bariatric Surgery, kind of came around and said, look, we need to get control of this. We need to be better at delivering a good, healthy, safe product. And so they certified centers as centers of excellence. We were one of the first ones to get this designation back in 2005. And so it can be done safely. You got to have the right people doing it. So you have to have a dedicated program, not only for post-op for the surgery, but for pre-op education, which is just as much important as post-op management of these patients. So we've made these very safe surgeries. Well, what are some of the complications to look for? Gastric, specific to each specific procedure. With gastric bypass, whenever we hook two ends of bowel together, leaks can happen, whether it's colon surgery or whatever. So leakage can happen. Sometimes it scars in too well, then an obstruction can happen. Sometimes we got to dilate that. With the lap band, it can slip. Very rarely, but we've seen some band erosions that have happened. The port underneath the skin can flip. The sleeves leak. Very rare complication anymore. When we first started doing the sleeves, some studies are showing about a 1 in 20 chance of a leak. That's pretty high at 5%. I've had one leak ever, and it was when I first started doing this. It was a guy that had part of his spleen removed at the same time, which I won't do anymore because he had bleeding related to that got infected, that then kind of eroded from the outside in. So a different mechanism for the leak with the sleeve versus the bypass. Well, we can have all sorts of intraoperative complications. Our equipment works really well. We've been doing minimally invasive surgery for 30 years now, and we've got these complications down to a real minimal. Anatomic variances. I went to do a gastric bypass on somebody and they had situs inversus. All their organs were backwards, but they're not just backwards, but they're not really where they belong. And so occasionally we run into some really weird problems like that.
Those whoops things.
Again, anastomotic leak happens at a pretty low level. Some studies as high as 10% back in the day. I've had 4 leaks in gastric bypass surgery in 17 years of doing this. Again, it can be done very safely. So we watch these patients for a day or two in the hospital. We're looking for some very subtle signs. You walk in the next day. Really, tachycardia is one of the things that you look for. You can just look at a patient's eyes and you can tell, hey, something's not going on right here. So experience plays a big part in this because, exam and some of our usual things we look at are unreliable in finding these things. DVT happens at a very low level. We get these patients walking within an hour of getting back from the recovery room. We're using Lovenox, so that doesn't happen very often. Very rarely, but blood clots can happen. And I've had one patient after a sleeve get a pulmonary embolism. One of the lowest risk patients that I have, but he got a pulmonary. He did fine. Everything's fine in the long run, but got to be very, very cognizant of this. We get them walking. We have those, leg squeezers on them all the time. We're using Lovenox and all the right things. It's still going to happen. Some of the late complications. It's one of the issues of deciding which surgery is best for your patient. Malnutrition, malabsorption can happen, particularly with gastric bypass surgery or the duodenal switch. And so we got to make sure they're educated really well about taking vitamins. Your intake is low, you've got to take vitamins or you will become deficient. Especially with gastric bypass, B12 and iron can be a problem. Have a hard time absorbing iron, and younger women sometimes have to get iron infusions. And so that's one of the relative advantages of the sleeve. There's less malabsorption, better absorption of vitamins. One study recently I saw that they followed patients for several months after the surgery and saw no difference in those that got vitamins versus those that didn't. That's a short-term study. I'm not prepared to tell sleeve patients not to take their vitamins, okay? Marginal ulcers, an ulcer where we hook the stomach to the small bowel, particularly in gastric bypass, it's a serious problem. We educate them a lot. They can never take a non-steroidal anti-inflammatory again in their life. They will get an ulcer. And we see it. We published a paper long ago. We had a dozen patients who just didn't listen. They'd taken tons of non-steroidals, came in with perforated ulcers. And so it's a real problem. So we really stress that. It's one of the really landmark studies in long-term outcomes of gastric bypass surgery. This is Walter Porres, who's been doing this forever. And you can see this was published a long time ago. So this was all open surgery back in that day as well. But he followed these patients for 14 years. And so, there's a little bit of weight regain in there. There's always that little blip, but the mean before was 300 pounds, over 100-pound weight loss, durable at 14 years. Again, the more education patients have before the surgery, the better they're going to do long term. We put everybody through an extensive program. We do a weight loss program for several weeks before the surgery to help make the surgery safer, any weight loss. The study we published on this, one of the things that turned out is the more weight you lost before the surgery, the more weight you kept off afterwards. So it's a little bit of a test of patience as to how dedicated are you? I mean, how much work are you willing to put into this? We love before and after pictures, right? This is a husband-wife team. This is actually one of the guys I operated on who had situs inversus. So I've operated on two. And he's done great with gastric. We both had gastric bypass surgery. So, well, I'll go ahead and stop there so we have time for questions and answers. So let's open up the floor, or unless you want to go to the cases, or
no, let's open up the floor. I just want to welcome Dr. Ramiak from Ontario. Irene, I see that you're with us. Thanks for joining. And are there questions or comments? Yeah.
My question is, what about older patients? How do you evaluate an older patient for this type of surgery?
That's a good question. There have been lots of studies done on this topic. We've done gastric bypass on patients as old as 76 years old. And so we take it on a case-by-case basis. Above about age 65, we kind of do a case-by-case basis. It is supported by Medicare. Obviously, some of these patients that are in their 70s, they need joint replacement. And the orthopedic surgeons won't do it because of their weight. They might be very healthy otherwise. And so they've done very well. There have been a lot of studies done on older patients that they made these safer surgeries. They're all done laparoscopically. We've been doing them laparoscopically for 17 years. So it's a case-by-case basis for them. We look at health issues, risk of surgery versus the risk of their medical problems, really.
If I could follow up on that, I guess what I'm thinking of a couple patients who are just so, their weight is killing them. They're going to die pretty quickly for a variety of reasons, that, sleep apnea, heart disease, etc. They may have, AFib starting in. I mean, but just very recently, within a year or two ago, they were relatively healthy with, a weight of 350 to 400 pounds. And so it's a case by case, but how do you think I should approach that to see if this is truly an option for them?
Yeah, I mean, again, we'd be happy to see them and talk about risks and things like that. But one of the things we will do in a patient, especially like that, is we'll put them through a pretty extensive program beforehand, not just of education, but of some weight loss. Let's get those medical problems under a little bit better control to make the surgery safer. And that's why I think we can offer this surgery to higher risk patients, older patients. So again, it's very generic. I know it's hard to give any specifics without looking at an individual case, but I don't think it should be ruled out based on age alone.
Okay, thank you.
Yeah, you bet.
Anybody else? Yeah.
There you go.
Was curious about nutrition to some extent. I've seen 3 or 4 big failures after bariatric surgery. Patients that came into me sometimes years after they basically failed. And I've seen one spectacular success, a woman I was playing pickleball with, and you would have never guessed she'd had the surgery. Asking about nutrition, my failed people seem to be following recommendations to eat more carbohydrates and a very balanced diet. The woman that was such a success said that she'd started weight regaining. She'd regained about 40 pounds after surgery, and she got worried. And she talked with her peers that had also had surgery. And they told her that she absolutely must focus on protein and start each meal with protein, and that this would help her keep the weight off. And apparently it's worked for about 10 years for her. Do you have any comment on what is a good nutritional regimen after surgery?
Well, and you know, we see that patients that come into our practice that had surgery elsewhere, they didn't get the education beforehand. I mean, that's ridiculous that somebody told a bariatric patient to eat more carbs. You know, that just doesn't make any sense whatsoever. And so we very much focus before surgery. They're on a high protein diet before the surgery, but we start a high protein diet right after the surgery as well. They're on a liquid protein initially, and we educate them very extensively about protein first. You get your protein first. You know, your between meal snacks might be some fruit or vegetables, things like that, but you focus on the protein first. You know, you don't drink, you disconnect fluid intake with eating as well. You know, you don't want to wash everything out of your stomach pouch if you've got a gastric bypass or a sleeve. So, you know, they don't eat within a half hour or don't drink within a half hour after eating as well. But no, very, very much protein is our first. We've obviously got to get other nutrients in as well. And these patients don't need special supplements long term, really. I mean, as long as they're tracking their protein intake, and we educate them about that. Our patients know how many grams of protein they're taking in. We're seeing them, you know, pretty frequently after the surgery, and that's our first question. All right, how many grams of protein are you taking in? You know, or they bring in a food diary, and we can go over it with them. I've got a PA and a nurse practitioner who see patients as well. We go over it, and a nutritionist that works full time as well. And if we see that weight regain, let's get on top of it. You know, my nutritionist has these back to basics classes she puts on to say, all right, what am I supposed to be eating? People kind of forget. People gravitate toward food that sits better on their stomach, that might not be the best food for them. So we always see a little bit of weight regain, but the perception out there is everybody regains their weight, and that's not true. I mean, that's really not true. Those patients that aren't regaining weight are off living their life. They're not coming into your doctor's office because they're healthy now. So it's interesting. The perception is that a lot of people regain weight when it's really a smaller percentage. Can it happen? Absolutely, absolutely.
I mean, the best studies that I've seen are all from the Swedish registries. And, you know, there's a clear demarcation, and this is not new data, but patients followed for 30 years almost following surgery, you know, and they stratified pretty well. Those who had standard approaches to therapy, no long-term weight loss, right? Lap bands, maybe there was 10%. But the surgery patients, you know, had maintained a 30% weight loss over many, many years, and mortality rates went down. And the issue that I would raise is what we see in patients is related to stigma, I think, that there's a certain stigma about having surgery for what others consider to be a disease of choice. And I think that that's where we really need to intervene with patients and support them in breaking from that model, right? This is a disease, you know? There's a lot about it we don't know, but clearly we know the ramifications of this disease, and we also know what is affected, you know? So I really do think that we need to be proactive, I think, with our patients in making recommendations. We do so many things without thinking twice about it, right? Somebody with we walked out gallbladders pretty
Yeah.
with a pretty low bar, right? So I think we need to recalibrate a little bit.
When patients come in all the time, they almost feel like they've given up, like they're taking the easy way out, and it's a real struggle to educate these patients. This is not the easy way out. You still are accountable for everything you eat and everything you do. So you can't just have the surgery. It's not going to do all the work for you. You've got to buy into this, and you can tell when you talk to patients in the office. You can kind of get an idea of who's ready for that and who isn't. And that's why they go through a pretty extensive process. They're going to see a nutritionist. They're going to see a psychologist. A lot of them go through weight loss programs, a lot of insurance-mandated programs. The university puts on a great weight loss program, medical weight loss program. And some of our patients have done so well in it, they didn't need to have surgery. And so, but there is a big stigma around this for sure.
And going back real quick to the nutritional question, the American Bariatric Association recommends limiting total carbohydrates to 50 grams a day. When we think about how much food might be able to fit into their stomach with reducing the chances of it stretching out, protein is absolutely vital to be first. And if they're eating, much more carbohydrates, it means then they're not getting their protein in.
Yep.
So protein first for sure is a key recommendation we find too.
Well, and that's one of the things about gastric bypass is that you can get dumping syndrome if you eat too many carbohydrates or too high fatty content food. So it's going to hit the small bowel immediately. You aren't getting that pyloric release, slow release of these foods, and so they get a real negative impact if they eat a high carbohydrate. That's one of the things about gastric bypass that I like it when patients get that, because now they're afraid of it. They don't ever want that to happen again. I've had some patients just ignore the symptoms and keep doing it where they extinguish that. But, that's the psychology as well. Everyone sees a psychologist. We want to know not if they're crazy, but what's their relationship with food. We might be taking their best friend away. You got to be ready for that. But we want to uncover any eating disorders. People can get into real trouble if they've got an eating disorder. And so we want to work with those patients extensively before surgery.
Are there other questions?
I don't know if it's my turn for a question.
Fire away.
Okay. I've had a few patients after surgery, and then, what about medication absorption? How does it change other medications? In particular, I'm thinking of like SSRIs.
Yeah. Well, and that's, I think, more with the gastric bypass surgery. That is really one of the big advantages of sleeve gastrectomy. The medication, food, but also medication follows your normal route. And so there is better absorption of medication with that. And we see some patients with gastric bypass, if they're getting dumping syndrome, things are going through too quick. We have to adjust medications, absolutely. Capsules aren't digested well. Some long-acting meds aren't digested well in gastric bypass patients. It's not getting that stomach acid to help break things down. And so we might have to alter the form of their medication as well. Or if they have a capsule, open it up. The problem is a lot of these long-acting ones, you can't open the capsules. And so we've got to go to a different medication or a different form of that medication. But that was a good question, yeah.
Is that something that the surgeon does as far as post-op? Or I know in my case, I was the primary care provider, and this was coming in, and I really was not familiar at all with anything.
Yeah, right. Well, and what we do for some of our outlying areas is we either deliver it to you directly. If we know you've got a patient of ours, we've got a primary care physician's handbook on how do we monitor bariatric patients post-operatively. What am I looking for? What vitamins do I need to be checking? Those kind of things as well. Some of it outlines a little bit of medication as well, some general guidelines about that too. So
you say
I don't like to leave you out in the dark.
Right. That's awesome. I'd never heard of that before. That's great.
Okay. So I think we have a couple of cases. I would like to get to them if we could, unless there are any other. This is a great opportunity. We've got Dr. Ganser. This is a once in a millennium.
Feel free. If you guys have questions, just call my office. I'd be happy to talk to you as well. We have a lot of resources in our office too that we can always pass on to you.
Quick question. As primary care providers, we're often asked to render our judgment regarding the safety of these surgeries with our patients and giving medical clearance. Is there a baseline for, let's say, an otherwise healthy, morbidly obese patient that you you look at? I mean, is this an full EKG, metabolic panel, and a CBC, or what do you like to see for these patients?
Well, I think it depends on the individual. If they've had diabetes and they're over the age of 50, we'd like all of them to get a stress test, a cardiac stress test, not just an EKG. And so, not everybody needs that. I mean, we're obviously operating on some very high-risk patients. That's why we're doing this. If you could fix all our medical problems before surgery, they wouldn't need the surgery. So that's a great question. It's got to be tailored to the individual. Patients over the age of 60, 65, we're going to do a cardiac workup on them as well. So they probably have some heart disease underlying that. And the anesthesia is the risk, not the surgery itself. It's the anesthesia, obviously, it's the risk. It's a real risk. Having said that, boy, anesthesia has been so safe recently. These surgeries are no longer 4-hour surgeries. They're an hour or less in the operating room. And so, we can offer this to a lot of people, but we want to make sure they're as safe as possible. So, yeah, I think looking at their heart is going to be one of the best things. That's the most common thing we'll do above and beyond some basic metabolic panels and kidney functions and things like that. Absolutely. So it's hard to give you a concrete answer for everybody, but we accept that these are high-risk patients. There are high-risk patients going in. But again, as surgeons, our bariatric patients are actually in better condition. We see larger, more unhealthy patients that are coming in for surgery of all different types. And that's why you see gallbladder surgery. Some patients die from that because they aren't prepared for it. They haven't been worked up. They haven't gone through the weight loss beforehand. One of the things I've done with my general surgery practice is a lot of patients that are going to get an esophagectomy or something. We'll do these certain diets with them beforehand that my nutritionists put together to make them healthier going into an operation. So we're kind of spreading that to our general population. There's some new products, the Nestle Impact Advance, got some great stuff for healing. Patients with big hernias that wouldn't heal before, we're seeing much better healing with that as well. So, again, we're not going to make everybody healthy going into this. It's about optimizing and looking for the major things we can affect before the surgery. If they got heart disease, we got to get that controlled better before the surgery.
Okay. I think let's move on. Okay. Well, we're a little over time, so I think I've got nothing to do, but I know you all have important work to do, so we'll let you all go unless anybody wants to stay on the line. Otherwise, we'll see you in a couple of weeks.
Thank you for having me.
Thanks, John.
Thank you.
This is great.
Thank you. Thank you.
Bye-bye.
Fantastic.